speakers in this session, Dr. Stephen Van den Broucke, Dr. Carl Boodman, Dr. Venkat Ramesh, and Dr. Haripriya Reddy Challa. So the two sessions, the beginning sessions will be online sessions and the later two sessions will be offline sessions. We'll have them here. I kindly request Dr. Sudhindra Rao, M, Professor and HOD, Department of General Medicine, K.S. Hegde Medical College, Mangalore, to kindly join us for chairing this session. And I also request Dr. Mukhya Prana Prabhu Sir, Professor, Department of Medicine, KMC Manipal, to join us on the stage for chairing the sessions. Thank you so much, sir.
Good afternoon. After the morning brilliant discussion and panel session, we have got 4 sessions, 2 foreign speakers and 2 offline sessions. So we have got first topic is neurosyphilis, because syphilis was considered as everything in neurology for about 15-20 years back, I thought, but still it is not gone. HIV is considered as a disease equivalent to syphilis with every manifestation. So to talk on neurosyphilis, we have got from the prestigious internist infectious disease specialist from Belgium, Dr. Stephen Van den Broucke, from the Tropical Medicine Institute from Belgium. He has got a significant number of publications, and syphilis is a great mimic. So neurosyphilis is a very interesting topic, which I would like to understand more because we have not seen many neurosyphilis cases. So over to you, sir.
Okay, thank you very much for the kind introduction. So indeed, I'm Steven van den Broucke. I was invited by your center and more specifically by Nitin Gupta, who is with you, with whom I collaborated a lot in the past years. So for me, it's an honor to speak about neurosyphilis. Neurosyphilis, I think you all know it's caused by Treponema pallidum. It's estimated that there's about 6 million infections per year of syphilis in the world, many in Africa, where it can be more than 2,000 per 100,000 people per year. And about 3 to 5% of syphilis cases are present as neurosyphilis. Now, neurosyphilis, there is a kind of shift in what was true in the past and what is happening today. You see the brain is there, but also the ear and the eye, they are becoming more and more important. And the tabes dorsalis, that's like an old, tertiary syphilis presentation, but there is a clear shift towards more early neurosyphilis, which I will explain during the talk. So if you look at the incidence in the population that is worldwide, it is going up, and in the last years it went also up. One of the things that is driving it, you see that in women the incidence is not really going up, but in men having sex with men, with people living with HIV, it is going up. Now, something on the natural history of neurosyphilis, which you have learned probably in textbooks, is there is symptomatic, asymptomatic, and then you go in primary, secondary stage, and then this late tertiary neurosyphilis, meningovascular. But many of these data, they are based on pre-antibiotic era estimates, and there is some change in the neurosyphilis manifestations today. So what I want to do is present you a case, and on this case I will ask you some questions. I hope technology doesn't fail, and that with an interactive polling system I can see what you as an audience are thinking. So a 43-year-old male who has been diagnosed last year with HIV, and he started antiretroviral treatment, and the last CD4 count was 263. His viral loads were undetectable. He presented with visual changes and eye pain for 1 month, more in one eye than the other. And you check with this kind of charts, you see that this actually his visual acuity has decreased, and bilaterally he has red eyes. You do a clinical exam, so vital signs are normal, neurologically temperature sensation, proprioception, deep pain sensation, reflex gait, they are all normal. So what will you do now? And for that, I will allow you to scan. If you scan the code, I will try it myself. So if you scan this code, normally you get into a polling system. So I give you, if you have your cell phone with you, you will. So if you can just give me a sign when most people have arrived at the place, what will you do now? The question. I can continue. Okay, so what will you do now? So I see microscopy, fundus, examination slit lamp. I see a lot of fundoscopy, microscopy, ophthalmology. So fundoscopy. So I see a lot of things. Choroiditis. Okay, so I see a lot of things related with the eye. So I agree. The patient is sent to an ophthalmologist, and what he detects, he says this patient has uveitis. I know this is not a course on ophthalmology, but just the eye has three layers. The sclera and the cornea are the first layer. The last layer is the retina. And then the uvea, that's the middle part of the eye, is a choroid, the ciliary body, the iris, and uveitis is one of an inflammation of one of these three structures. And there is anterior, which is more the iris and the part in front of the lens. There is posterior, which is the choroid, and intermediate, which is the ciliary body inflammation. That can be uveitis. And anterior uveitis, it's about 90% of the uveitis presentation. So also, this is not this patient, but a slit lamp, which I had seen in your suggestion, was done. So there were posterior synechiae, this red arrow in the lens, pigment deposits in the anterior lens capsule. And what you can also sometimes see in anterior uveitis is inflammatory cells that, due to gravity, they arrive in the anterior chamber of the eye, causing hypopyon. So now, yeah, uveitis. I think uveitis, it has a broad range of differential diagnosis. It can be unilateral, bilateral. There are a lot of inflammatory syndromes, Behçet's disease, systemic lupus, medication. Often no cause is found. Idiopathic malignancy, sarcoidosis, but infectious, you see herpes, toxoplasmosis, varicella, but syphilis is among the infectious causes of uveitis. So you know that you have this patient who is diagnosed last year with HIV, and what would be the best next step for you with this presentation? Is it lumbar puncture for bacterial causal cell count, protein, and glucose, lumbar puncture for RPR, cell count, protein, glucose, and serum RPR, lumbar puncture the same, but now you choose VDRL, cell count, protein, glucose, and serum RPR, an MRI of the brain, or you do serum RPR and VDRL, and if positive, you do a more confirmed syphilis test, TPPA or TPHA, and if positive, you treat. So what is the best next step? So you can vote normally. I will check on my phone whether you indeed you can click on the options. So I see there is about 40% will do an LP for VDRL cell count and then serum RPR. MRI of the brain, some people, and some say serum RPR, VDRL, and if positive, you do a confirmatory syphilis test, and if positive, you treat. So in the last option, there is no lumbar puncture. Of course, I agree. Bacterial culture, if syphilis is in your mind, it will not grow. I think you're. But a correct option is the last one. I'm not saying that the third option is completely wrong, but there is a tendency towards the last option, and I hope I can elucidate the arguments during the presentation. So what are criteria of neurosyphilis? Different countries, different guidelines, they have slight different definitions. So in it's like CNS or ophthalmological signs plus serological evidence, and some definitions they say plus VDRL positive in the CSF or proteinuria or white blood cell count elevated in the CSF. So some they have lumbar punctures as a criteria. You see that this is a German algorithm, and if first you start with, they have the reversed algorithm. They start with more syphilis specific test. If it is negative, you have excluded. Positive, you do an LP, and then the cell count, whether it's elevated or not, you have a whole algorithm. Just different countries have different algorithms, and I don't think that there is an absolute right or wrong. Just know that in people living with HIV, so the cell count may be already raised due to their HIV, and there are people that say that this cutoff of 5 mononuclear cells per microliter, that it is actually too low, and you will have a lot of false positives. So in HIV, they say you might consider a higher cutoff of 20 white blood cells per microliter. So, okay, I give you the results of our patient. The RPR was positive. It's conferred with the treponema specific test, the TPA, which we are often using. And a lumbar puncture, we will discuss whether this was necessary or not. It was done. White blood cells were raised. There is proteinuria, and the VDRL is positive. So, in this patient, what is the preferred treatment? Is it aqueous crystalline penicillin, 4 million units 6 times daily, or you take the total of 24 million units as a continuous infusion for 10 to 14 days? Is it benzathine penicillin G, 4 million units IV 6 times per day for 10 to 14 days? Benzathidine penicillin G, 2.4 million units IM weekly for 3 weeks, ceftriaxone 2 gram daily for 10 to 14 days, or doxycycline 100 milligram twice daily for 14 days. So you can vote what you think is the correct option. So I give you a few seconds. I see there's 12 people who have voted. I don't know how many you are there. So I give you 5 more seconds. 5, 4, 3, 2, 1. Okay. So I see the first option, aqueous crystalline penicillin, has the majority of the votes. Then there is the second place is shared between benzathine penicillin IM for weekly for 3 weeks, and some people of you say ceftriaxone would be your option, and benzathine penicillin for 4 million units IV 6 times per day for 14 days. Now here, if you look at current guidelines, the first option is the correct one. So that is what and I think there is less discussion. This is what most international guidelines are doing. The fact that guidelines say this, it doesn't mean that other options might be completely incorrect. But something that is known, if you go back, the benzathine penicillin G, which has a longer life, that one is not an option, not IV and not IM, because even at high doses, there is no trypanomacidal concentrations that are reached in the cerebrospinal fluid. So option B and C are not options. Option E, doxycycline, I will tell a word for it, but it's not correct, because if you would use doxy, it could be an option, although it's more a research field, but the dosing is too low. Now, what do guidelines say? If you want a very good review article on syphilis in general, you read a paper written by Ganem in 2020 in the New England, and on neurosyphilis, paper written by Europa in 2019 in the New England. They are review papers, excellent review papers on these topics. So our patient, yes, he had neurosyphilis, with his lumbar puncture being positive and ocular symptoms. So guidelines say you should use aqueous crystalline, penicillin G, can in IM plus probenecid, which depends whether it's available or not. So this is the general syphilis article, but for early and late neurosyphilis, it depends a bit on where you are. The New England, it's an American journal, so the aqueous crystalline penicillin given in every 6 hours or in continuous dose, that is their first line treatment, while in UK penicillin G procaine IM with an probenecid is the first option, and in Europe we usually use benzyl penicillin, about 4 million units 6 times daily, and there are alternatives. So it depends also a bit where you are living, what is the first line option. So if this patient, neurosyphilis, what can you expect when you treat and the treatment response is good? Now, the meningeal syphilis, the symptoms, usually if you have meningitis syphilis, especially early syphilis, there will be a clear clinical improvement. If there is really already in late syphilis significant parenchymal damage, the treatment will limit disease progression, but you don't have you are not guaranteed that it will return to normal. Ocular and otic syphilis, the longer the symptoms were present, the less likely they will respond. So, and also what is seen is that prolonging the courses of antibiotics has not been useful. What can you expect in the lab after treatment? So normalization of a serum RPR or VDRL titer predicts normalization of abnormal CSF parameters after neurosyphilis treatment. So you don't have to do LPs for follow-up. An exception could be an HIV patient who is not on antiretroviral treatment. Then this statement is not true. So therefore, only do an LP if there is an inadequate serum RPR response after treating. Now, is the treatment of symptomatic and asymptomatic neurosyphilis, is it the same? Yeah, it's a simple yes or no question. So normally is it the same or is it not the same? I see I give you 5 more seconds. 5, 4, 3, 2, 1. So yeah, two-thirds say yes, 1/3 say no. Well, actually, it is the same. So that there is no difference if in treatment, and also under treatment of asymptomatic neurosyphilis may lead to relapse as neurosyphilis, symptomatic neurosyphilis. So yes, if it is diagnosed, especially in HIV treatments with low immunity, there is no difference whether the patient is symptomatic or not. Now, if a patient is allergic to penicillin, which is often the first line regimen prescribed, what can you do? Now, this is not a general syphilis advice. I don't know if you are familiar with the PENFAST rule, but one thing is to go and check, is this patient really allergic? Because many patients are incorrectly labeled allergic to penicillin. If the exposure was less than 5 years, more than 5 years ago, only you don't get points. If it is anaphylactic, severe cutaneous, 2 points, and if treatment was required, 1 point. Now the score says, as long as the score is 2 or 1 or 0, 1 or 2, actually it's quite safe to give a re-challenge to beta-lactam antibiotics, because the negative predictive value of true penicillin allergy is very high. If the score is higher, there are options for desensitization if it's available, or ceftriaxone or doxycycline. I'm not going to go into what is syphilis. So the primary syphilis is an ulcer, secondary syphilis, rash, fever, systemic symptoms. But this also comes from this New England Journal of Medicine, the modern epidemic of syphilis, primary, secondary, early latent, and you see they can make a circle, become symptomatic, latent again, late latent, which can lead to tertiary. But as I have explained, CNF invasion in 40% of patients with primary infections is occurring, and 10% of them will have asymptomatic or symptomatic neurosyphilis, but ocular and otic syphilis are also due to somehow CNS invasion, and these ones may lead to late neurosyphilis, which is considered also a tertiary manifestation. So neurosyphilis, meningeal, usually in the first year after infection, meningovascular complications with endarteritis obliterans in a few years later, and the real parenchymal infection, tabes dorsalis, general paresis. It's later. The humas, that is really what you see after many years. But ocular and otic, they can be seen at any time. This I gonna just show you. I think I had it open here. So this is the movie of a patient. Oh, I have it was ready, but now it's not ready. So this is a patient with tertiary syphilis. Loss of sight, loss of hearing, pains in the legs, in the whole body, numb hands. So you see the gait pattern. And this is also called, you see the pupils, they don't react to light. There is no constriction of the lens. So it's not occurring. And actually, when you ask the patient to accommodate, to look centrally, you see that there is constriction of the lens. And this is the Argyll-Robertson sign, which is suggestive of also late neurosyphilis with brain invasion. And the last thing is sensitize, like vibration. He doesn't feel it. So the patient doesn't feel. So that is just a small video that is showing clinical manifestations more of the late syphilis. But as I've explained, there is much more early syphilis today because we are in the antibiotic era than in the late neurosyphilis. So some examples of really this parenchymal involvement, which may lead to dementia, seizures, severe headache, and large gumata in patients. So in the CSF, there was initially this question: you use Vidiral or RPR or other tests? Actually, VDRL in the CSF is highly specific, but you have to be aware that it's less sensitive than RPR. But RPR in the CSF is also not really recommended. It's more a very useful test in the serum for follow-up of treatment. So general syphilis testing, I'm not gonna go in details. You can read this article. It explains very clearly how to repeat. You have the traditional and the reversed algorithm on syphilis and the interpretation. I'm not gonna go in this, but specifically for the lab sensitive and specificity of lab tests of neurosyphilis, you see that serum tests, VDRL and RPR, will almost always be positive. But in late symptomatic syphilis, sensitivity decreases. And also notice that CSF VDRL, if it's specific, very specific, but you miss some cases. There are also fluorescent troponin antibody absorption tests with high sensitivity, but also specificities than one of the problems. So it's not so easy, the interpretation of CSF and the negative or positive predictive values. So you see that later, initially CSF VDRL will be more positive, but the later you are, the more chances that it turns negative. And these tests, they remain sensitive, but they lose on specificity. So are there indication to perform a lung puncture for neurosyphilis in an asymptomatic patient? So are there indications? And if yes, which are indications? So I let you answer. So I see yes, and if somebody can add suspect TB, suspect meningitis, a very high titer of RPR. So you say that the titer might be HIV. I see some consider it suspected as tertiary, or okay. I see you give good suggestions. Otic manifestations. Now I'm gonna go something on lumbar puncture for neurosyphilis in an asymptomatic patient. There is a group in Brazil, and what they did is they have presented cases to a whole different group of clinicians. Some who had easy access to LP, some where they had to refer, where it was more challenging. And their conclusion is that the management was very heterogeneous. So I'm not going to go in the details of this table, but the refer for lumbar puncture for neurosyphilis investigation with high CD4 cell count in an HIV patient, it was lower, but some 20-25% do it, others don't. When the CD4 count is low, many clinicians did it, but there are also clinicians that don't do it, and there are other situations. So you see that the management, it was quite dependent on which doctor is sitting in front of you, whether you will be referred for LP. So they conclude it's one of the most debated topics, like the need and timing of CSF investigation in HIV co-infected patients. And what in the past years, the recommendations have been changing, and prior studies recommended a very aggressive approach with a lumbar puncture based on CD4 count. There is a shift towards less invasive approach, and actually that whether the patient is HIV infected or not, there is no difference to check for this. This comes from this reference number 16, which are actually CDC guidelines. And what do they say? The prognostic significance of CSF abnormalities differs between HIV and persons and infected and uninfected persons, but whether this, I should have highlighted this, whether the prognostic significance, whether it changes, it is unknown. And they conclude that actually Yeah, neurological, ocular, which is debated, which I will show, active tertiary syphilis and treatment failure, late latent or syphilis of unknown duration are needed. So some people say all HIV infected persons will need it, but there is a tendency to shift away from this. So what do they actually say? Yeah, the late latent, this group should have it even if they don't have any symptoms. Tertiary, but tertiary usually they have symptoms, and symptomatic early syphilis and ocular. The otic they don't. So this is an interesting article of 2 years ago, advances in neurosyphilis, and they say the CDC suggests a lumbar puncture should be given to people living with HIV with neurological signs or symptoms or serofast status, so it means no decreasing titers after improvement, and or tertiary syphilis. Of it, another journal says otosyphilis CSF is usually normal and is not recommended in otic syphilis. And they also refer to another guideline paper of the MMWR Society, and they say, when should you do it? Neurological disease like cranial nerve dysfunction, meningitis, stroke symptoms, altered mental stage, and CSF evaluation is not always needed for patients with ocular syphilis, so they even go further. It's not only otic but also ocular, only if there is evidence of cranial nerve involvement, nerve 2, 3, 4, 5, 6 dysfunction. That is an indication to do an LP. But a thorough cranial nerve and ocular examination is recommended, and a thorough ENT otic evaluation is also recommended, which you in your initially many of you said, yes, we want more details on the ophthalmological examination. For time purpose, I will make the slide.
Can you wind in another 2 minutes?
Yes, I am arriving in my last slides.
Thank you.
So this I will skip I will send you this, but it summarizes it. So what do we do at ITM? Who needs an LP? If there are neurological signs, including otologic and ophthalmological, unless one decides to treat, even if the LP would be negative. Active tertiary syphilis is an indication, aortitis, rheumata. Treatment failure is an indication, and you see the definition of treatment failure if RPR goes up or fails to decline to titers. And so we say in otic and ocular syphilis, RPR is enough. It's not needed if you have a positive RPR and clinical symptoms compatible. And why? Often they have false negative CSF, and you are at risk of undertreating. So for us, the clinical picture of otic and ocular syphilis with a positive syphilis serology, it's enough to give treatment. Just a last minute on the future of neurosyphilis. The standard of care is penicillin IV. This is not based on randomized controlled trial. It's based on habit and history. IV ceftriaxone, it's a research question whether outpatient ambulatory treatment or oral treatment would be okay. And there is some evidence that ceftriaxone and oral doxycycline might be useful and non-inferior, but it's more anecdotal data, and they say randomized trials are needed. There is fear of introducing antibiotic resistance if you use ceftriaxone compliance. So we proposed a 3-arm study, randomized control, where we also would do antibiotic resistance surveillance. We would do impact on social life, quality of life, convenience, treatment satisfactions, adherence. Linezolid failed. It was published this year, so that is not an oral option. So why are we not doing this study yet? The problem is in 6 centers in Belgium, it would take us 3 years. We had funding for this, but they challenged us that the sample size might not be enough. So we needed more patients, which means in Belgium, Holland, more than 20 centers. You have to mobilize neurologists, infectiologists, ENT specialists, and more than 5-year inclusion time. So we actually would want to collaborate with a center that that has more patients, because it would decrease the time of the study. Because if you prove that ceftriaxone is non-inferior, this would be good. If you officially prove that doxy is really non-inferior, that would be really a complete worldwide game changer. So it has been done, but it's not been proven. So that was my last slide. So with that said, I'm open for any questions from the floor, if there are any questions. Thank you very much.
Thank you, Stephen, for a wonderful lecture on a very interesting topic, neurosyphilis, which we have heard, and we had heard that it's a differential diagnosis for all neurological problems, and the importance of lumbar puncture, role of crystalline penicillin, and the research question of ceftriaxone, doxy, which you are planning. Thank you for the wonderful session, but floor is open for one question for the lack of time. Anybody has got any question for Stephen? If they don't have question, I can ask, ceftriaxone should be equally effective, and should be a good choice for this. But crystalline penicillin must be superior. Why not ceftriaxone was not been tried so far?
Well, there is indeed evidence that in France a study has been done that had shown non-inferiority, and that was even pointing towards superiority. But it was a very small amount of patients, and it lacked power. So what you actually need is a bigger trial that officially proves that it is superior. The same for doxy. It's a spirochete. So it's not because penicillin, yeah, it's true there is no resistance, but giving it IV 6 times daily, it's cumbersome. People have to stay hospitalized, and there is no reason why doxycycline would not be efficient, but in higher doses, twice daily, 200 milligram for 4 weeks. For Lyme's disease, which is borreliosis, which is also spirochete, there has been a big paper with proven non-inferiority. So I think it is a reasonable option, but we need more evidence before guidelines will change all over the world.
Thank you, Stephen, for a wonderful and joining from the online, and it was a really pleasant experience to hear something neurosyphilis, which we don't commonly talk, and such as you told that modern epidemic of neurosyphilis. Thank you from the Manipal group. Thank you.
It was my pleasure. Thank you.
Okay. Good afternoon. For the next topic, I invite Dr. Carl Boodman. Dr. Carl is a PhD candidate and clinical investigator, and he is affiliated to Infectious Disease and Microbiology Institution in Belgium, and also affiliated to University of Manitoba in Canada. He has more than 41 publications, and when they come negative, we'll be in a fix how to go about further. So to speak on this topic, I invite Dr. Carl once again. Over to you, sir.
So it's a pleasure talking to you again. I'm sorry I can't be here in person this time around, and I hope to visit again soon. Thank you for that lovely introduction. So today I'm going to talk about culture-negative infective endocarditis in certain low resource settings. And I wanted to start by saying that I have no conflicts of interest, no disclosures. There's one little disclaimer. This is not an exhaustive overview, and there is a tiny bit of redundancy with one of the talks I gave probably a month ago about Bartonella quintana endocarditis in low resource settings, but there shouldn't be all that much redundancy. So there's something new for those of you who attended the old talk. So who am I? I did an MD at McGill University in Montreal, then internal medicine in Vancouver, infectious disease microbiology in Winnipeg, and as was mentioned, I'm a PhD student in University of Antwerp, Institute of Tropical Medicine. I do some part-time consulting work, and my funding comes from a mix of Canada as well as elsewhere. And I collaborate with Dr. Nitin Gupta on the Center for Tropical Febrile Illness, which is a great pleasure for me. So a brief outline today. So we're going to start with some definitions, the background. We'll talk about, and we'll focus on 3 pathogens: Bartonella quintana, Coxiella burnettii, and Trophorema whipplei. And then we'll wrap up. So what is culture-negative infective endocarditis? So This really relates to no etiology after 3 blood cultures, usually in an automated blood culture system that has been incubated for 5 to 7 days. Depending on which reference you use, often the routine cultures are for at least 5 days, but often no more than 7. Now, there's 4 reasons, and probably others too, but 4 major reasons why cultures are negative. One big one is that antimicrobials are given before people take blood cultures. This can especially be problematic with, the streptococci, which can be lysed quite quickly. Some of the other ones, as you can see, I'm sure in your clinical experience, you'll see that, even if you give 1 or 2 antibiotics before Staph aureus, it often remains there. But in general, antimicrobials before blood cultures can cause false negativity. You could also have some inadequate microbiological techniques. The third, which is the one that I'm really going to focus on in this talk, is infections with fastidious bacteria. These are intracellular gram-negative organisms, and I'm arguing that they're disproportionately present in low-resource settings. And then the fourth reason is that these are non-bacterial pathogens, so fungi. And here I'm explicitly excluding some of the non-infectious thrombotic ones or the autoimmune ones like Lindman-Sachs or Morantic endocarditis. So I'm not really going to refer to those. So I'm going to really focus on number 3 today. And I just wanted to mention that these organisms, while some people think that they're very obscure, have actually featured prominently in the most recent update to the modified Duke criteria. And you can see here, this is the 2023 update for diagnosing cardiovascular infections and infective endocarditis. And you can see this is the abstract. One of the major criteria updates is enzyme immunoassay for Bartonella or PCR for Bartonella quintana, as well as other organisms. And I'll just show you here, and I'll quote just to kind of hammer this home. In the first modified Duke criteria, Coxiella burnettii antiphase 1, so that's the chronic form, immunoglobulin greater than 1 in 800 was a major criterion. So that's what we had in 2003. And then in the current one, the revision includes serology for B. quintana, B. henselae as a major criteria, or an identification with PCR of either any Bartonella species, Coxiella burnettii, or Triphorema whipli. So these are the reasons why I'm focusing on these 3 organisms, which are major criteria updates. And you just see it in a different form here, just in case I haven't convinced you. And in bold, you can see that these are the updates. And these are 3 culture-negative, fastidious, often intracellular organisms, especially Coxiella and Bartonella. Trophorema whipli is a little bit different. And as you can notice, most of the diagnostics rely on either serology or molecular, so PCR, sequencing. Now, one thing that I'm curious about is whether the next update in 15 or 20 years will include brucella, because brucella and endocarditis is is underdiagnosed, but I guess we'll wait and see. So we'll start with Bartonella quintana. Some key points: gram-negative bacillus, transmitted by body lice, first described in World War I, and you can see the description on the right by Dr. Graham of this relapsing febrile illness. But then in the last 30 years, there have been outbreaks tied to homelessness, to refugee camps, and it causes a chronic bloodstream infection, often months, sometimes years. The longest documented bacteremia is 8 years. That often has mild symptoms until there's culture-negative endocarditis. Here you can see to the right pictures of body lice in someone's clothing of a patient I treated. To the left, you see all the kind of blood staining of what body lice can do when people are itching. Here are some, they seem like non-specific scabs or microabrasions. And these are the types of abrasions where Bartonella quintana enters the bloodstream. And this is a picture of body lice. So Bartonella quintana, bloodstream infection, the body lice take a blood meal. The B. quintana replicates in the arthropod, and then when the arthropod bites, it also defecates, creating this biofilm with a lot of Bartonella quintana. When people scratch, the biofilm or the Bartonella quintana enters the bloodstream and causes a chronic infection in the erythrocyte. So almost like malaria, it goes in the red blood cell. Now, for a long time, people have argued about the Europe-African gradient of B. quintana. So you see these increasing percentages as you go down from Sweden all the way to Tunisia, and I'm sure this gradient goes on even further. But most of this, I think, is really a socioeconomic one rather than a climactic one. There are cases from, Siberia, I've seen cases from northern Canada. So, I don't think this is really a climactic or a geographic one, but rather a socioeconomic one. Now, I'm just going to talk a little bit about Bartonella quintana, and this is a paper we published with Dr. Gupta. And I want to focus how there's really Bartonella quintana throughout a lot of the world. These are 40 countries here, but there's a really high prevalence in Ethiopia, and in a prospective cohort in South Africa, it's the second most common cause of endocarditis after Staph aureus, so more common than streptococci species. So even though it's very underdiagnosed, there does seem to be quite a prevalence, especially in certain low resource settings, despite a lack of diagnostic capacity often. So in this review, we had 167 cases. These are all molecularly proven, and over a third of them were from low and middle income countries. But all of the ones acquired in sub-Saharan Africa, except for in South Africa and Senegal, were actually diagnosed in a high-income country. So in some ways, we're getting a signal from those in a high-income country who immigrated, but they were acquired in sub-Saharan Africa. And this is often a disease of young people. So the mean age is 46 years. And you can see there are some differences with the low and middle income countries, high income countries. In low and middle income countries, more likely to be rural, housed, and have some pre-valvular disease, maybe rheumatic heart disease. And you can see this is different than the homeless male population from high income settings. Interestingly, fever occurs in the minority. More patients present with heart failure. This is kind of structural damage. And there's a long delay of symptom duration before presentation. So over 5 months. And around a quarter of these presented with embolization, either to the brain or the spleen. And these are large vegetations, on average 1.7 centimeters. This is not small. This does not happen overnight. It's a chronic process. And I just wanted to emphasize that people often say, okay, this is a disease of older, homeless men in high-income countries. Well, in low and middle-income countries, that's not true. There's a disproportionate number of pediatric cases from low and middle-income countries, as you can see here, Algeria, Senegal, a strong signal from Ethiopia. And then we saw one case from northern Canada in an 11-year-old, which is really the only one that was acquired in a high-income country. And overall, the case fatality rate is around 10%, even with treatment. That includes cardiovascular surgery, months of antibiotics. And the links with mortality are if you're age over 65, if you have fever, renal dysfunction, and if you don't have cardiovascular surgery, if you have a 1.7 centimeter vegetation and you don't remove it with surgery, there's a high risk of mortality. Okay, so we talked about some definitions. We talked about Bartonella quintana, IE. And now we're going to briefly talk about Coxiella burnetii, IE. So this is a picture from the CDC, and I want to kind of quickly describe what they show, but also show some of the limitations. So they say, okay, Q fever causes a flu-like illness, it's zoonotic, transmitted by goats, sheep, cows, other animals. In French Guiana, they talk about it being linked to sloths in the forest. And, there's a lot of transmission after these animals give birth. So veterinarians, farmers are at high risk, but that these spores can actually be carried for a long period of time in the wind. So for many miles. So you could actually be infected by breathing it in, even if you live miles away from where the infected animal was or gave birth. Now, I just want to show you that in the American CDC, they focus on these white American farmers, and this doesn't really reflect the full picture of Bartonella Coxiella, which occurs, which can occur in low and middle resource countries. So this is one of the things that I mentioned. Coxiella burnetii can cause any number of diseases: acute pneumonia, hepatitis. There's exposure to products of conception. There's occasional transmission from ticks, dermacentor ticks. But what we're going to focus on is the chronic disease with endocarditis. So it was first called Q fever in the 1930s in Australia. It's not gram stainable, so you need another stain called Jimenez. It's intracellular in this vacuole, often in macrophages, and it often affects people with pre-existing valvulopathy. So unlike Bartonella cutanea, which occasionally affects those with pre-existing valvulopathy, this one really loves prosthetic valves. It loves bicuspid aortic valves or any type of valvular damage. And it's associated with high titers to phase 1. I won't go into all of the details of the serology, but it's also associated with anticardiolipin antibody positivity. Now, the really tricky part about Coxiella is that the valvular vegetations are small, so really unlike Bartonella, and often people present, in most cases, with just worsening valvular insufficiency. Valvular vegetation seen on echo or even in pathology are only found in the minority of the cases. So this really creates a diagnostic challenge. Now, I wanted to just emphasize that there's actually quite a burden in low and middle resource settings. So you can see that there are some high serologic titers, especially in Egypt, 10 to 30%. And in some cohorts, Q fever accounted for 2 to 9% of all febrile illness hospitalizations in sub-Saharan Africa, and 1 to 3% of endocarditis cases, but really data is quite lacking. In India, there's only a couple of reports, but then when you look at the actual seropositivity in herds, it's actually 25% in cattle, 8% in buffalo. Okay, so we've talked about some backgrounds. We talked about the 4 reasons why cultures may be negative in endocarditis. We talked a little bit about Bartonella cutanea. We talked a little bit about Coxiella burnettii. This is not a complete review. It's just kind of an aerial description and view of these organisms. We talked about how these organisms feature in the update to the modified Duke criteria for diagnosing endocarditis. And now the last one, we'll talk about Triphorema whipplei. And this one really has, I've got to say, probably the least evidence, but is quite fascinating. So this was diagnosed or first coined in 1907. And it was not coined with endocarditis at all. It was described as this kind of mix of gastroenterologic disease with arthritis and a gradual loss of weight. So George Whipple described it as a loss of weight and strength, stools with neutral fat and fatty acids, indefinite abdominal signs, and a particular multiple arthritis. And he called this Whipple's disease. But then later on, it was discovered that endocarditis was not associated with classical presentations of Whipple disease. So you could have Trophorema whipplei endocarditis, but none of the classical signs of Whipple's disease. And often, it's kind of similarly to these other fastidious organisms, there's fibrosis, slight inflammation, and it's slowly progressive. So this is different than your acute endocarditis that causes, valvular perforation. This is minimal inflammation, slowly progressive over time. And there's very rare reports in low resource settings. There's only really 3 from Brazil, as far as I know. And most of the data on this is from Europe, either France or Germany. So some people, in some big cohorts, they've even described that Trophorema whipplei is quite common in culture-negative endocarditis. In this cohort in Germany, it was found to be the most common pathogen, but some people have made this claim about Bartonella, Coxiella, Trophorema, depending on the cohort. So it kind of depends maybe on the patient population. One thing I wanted to emphasize is that while there is almost no endocarditis cases from low and middle resource settings, Trophorema whipplei is associated with kind of lack of access to clean potable water. And for those reasons, it's actually quite present in some low and middle income settings. And in this study in Senegal, it was actually found to be detected in a number of blood specimens from febrile illness patients. So at 5% in Senegal. So there's clearly a signal from low and middle resource settings, low and middle income settings and low and middle income countries, but it's really not diagnosed. So sometimes we argued in a recent publication that maybe these culture-negative bacterial pathogens, especially those causing endocarditis, may be neglected infections really of poverty. We know that for Bartonella quintana, it's associated with body lice. Coxiella burnettii, I mean, there's large seroprevalence among cattle and livestock. We know that there's more close kind of animal husbandry in many countries where there's kind of more people who engage in farming and engage in closer contact to animals. And then for Trophorema whippeli, with the lack of access to potable drinking water. So, these risk factors are there, but it's a matter of actually seeing and investigating with appropriate serologic and molecular tests whether the diseases are actually there. And as we saw, a lot of these actually present with heart failure rather than, fever and the other classical signs of endocarditis. So this is a collaborator and colleague, Alfonso Pecoraro, who has the cohort in South Africa. And he wrote an article in The Lancet just a couple of years ago calling for more data. And he says, a unique feature of infective endocarditis in Africa is the high rates of blood culture negative infective endocarditis, an important contributor to the high rates of blood culture negative endocarditis. He says, yes, it might have to do with antibiotics before, but he says it's really reflected the non-culturable or difficult to culture organisms, particularly Bartonella species, being the most common. Yep, I'm on my next slide. So thank you very much. So the conclusions: infective endocarditis in low resource settings, disproportionately culture negative, data is severely lacking. So we discussed the background, Bartonella quintana, Coxiella burnettii, Trophorema whippeli, and we concluded. There's a lot of different people who are engaged with my work, and I welcome any questions. Thank you so much for allowing me to speak today.
I thank Dr. Karl and congratulate him for completing in a very short span of time a descriptive lecture. If there are any questions from the audience. Okay, sir, may I ask a question? We have been reading about HACK organism in our textbooks. Very commonly, these are the end of the infective endocarditis list. Yeah. So
HACK.
Yes, HACK organisms. So.
Yeah. So great question. So the HACK organisms were non-culturable when you didn't have like automated blood culture methods, but now with current methods, you can actually culture HACK organisms. So that's why I didn't include them here, and that's why you'll see that in the update to the modified Duke criteria, there's less of a focus on HACK, and you don't need the serology or the molecular as much, and that's because now actually HACK organisms are cultured. Like you can culture Kingella, you can culture Haemophilus, and so in some ways, HACK organisms do cause endocarditis, but they're now culture positive with modern culture techniques and automated CO2 monitoring and things like that. Does that make sense?
Okay. So thank you so much, sir, for joining.
It's a pleasure.
Yeah. So
it's a pleasure. Have a great conference.
Thank
Take care.
you, sir. Thank you.
Thank you to Kavita ma'am for giving me this opportunity. It's really an honor and a privilege to be here. So my topic is top 10 papers in tropical ID, and I have certain criteria for these selection of papers. One is they had to be published not necessarily in the last 1 year, but I have extended it to 1st January 2023 in a peer-reviewed journal, and focused on tropical infections, and HIV and TB have been included, but I think there's just one study related to that. They are clinically relevant and relevant to the Indian context. And when I give my presentation, you'll see I've grouped them by disease, and I have used a bit of personal discretion in choosing them, really. So the first article, and probably a real game changer and practice changing study, which was published in the New England Journal of Medicine, was this paper on intravenous doxycycline, azithromycin, or both for severe scrub typhus. And as you can see here, ma'am is one of the authors. So just very quickly, so scrub typhus is a major problem. There are about 1.5 lakh annual deaths, and the untreated case fatality rate is 6%, but it could be as high as 70% in severe disease. And this can, severe disease develops in approximately 1/3 of hospitalized patients and can lead to death in approximately 1/4 of cases despite therapy. And really, if you look at the previous treatment, it was doxycycline or chloramphenicol, but we didn't really have studies until this one. So this was the INTEREST trial, the intravenous treatment for scrub typhus, to compare the efficacy and safety of 3.
Venkat, we discussed this in the morning.
Oh, okay.
So
sorry. Then I will
go to other studies. And
yeah.
If you have comments later, you could come back.
Sure, ma'am. I'll do that. I'm sorry. Okay. So the second study is the live attenuated tetravalent Butantan dengue virus in children, dengue vaccine in children and adults. So if you look at this study, this was it's an ongoing phase 3 double-blind randomized placebo-controlled trial which was conducted in Brazil, which looked at the efficacy of a single-dose live attenuated vaccine, that is Butantan DV, for dengue virus prevention in children, adolescents, and adults with or without previous exposure. So they had 16,235 participants in a 2:1 ratio to receive either a single dose of the vaccine or placebo, and the pre-specified analysis at 2 years of follow-up. The primary endpoint was the incidence of symptomatic virologically confirmed dengue more than 20 days after infection, regardless of previous infection. Okay. Now I'll show you the graphs, but during 2 years of follow-up, there were fewer cases of virologically confirmed dengue in the vaccine group, and the vaccine was also safe and safe with no real adverse events. And the dengue serotypes that were detected were mainly 1 and 2, and no 3 and 4 cases occurred. No safety concerns were identified, and a low incidence of severe disease really precluded analysis about vaccine efficacy against severe dengue. Okay. So as you can see in this graph here, symptomatic virologically confirmed dengue more than 28 days after injection, the incidence was much lower in the vaccine group than in the placebo group. And the most common adverse events were headache, fatigue, and rash, with rash being significantly more common in the vaccine group than in the placebo group. So really, I think the take-home message is that this single dose of Butantan DV prevented symptomatic dengue 1 and dengue 2 infection in children and adults, regardless of dengue serostatus at baseline, through 2 years of follow-up. So this is something that, and we know that dengue is a major problem in really all across India. So hopefully this is, we need to look at the dengue vaccine horizon. And moving on, there was another vaccine, but this is not a phase 3 trial. This is the study on the tetravalent dengue vaccine, TV005, and this was a study done in Bangladesh using for safety and durable immunogenicity. So healthy volunteers were recruited here, 1 to 15 years, randomly assigned 3:1 to receive a dose or placebo, followed up for 3 years. Study was double-blinded, unmasked at day 180, and if you go back to your like the COVID vaccine papers and you look at them, the initial studies would look at post-vaccine seropositivity, and this is what was done here too. So safety and post-vaccine seropositivity by day 180 using serotype-specific neutralizing antibodies, that is the plaque reduction neutralization assay. Secondary outcomes included viremia, impact of past dengue exposure, and durability of antibody responses. So the vaccine was well tolerated, adverse events were mild, rash was the most common, 26% of vaccine recipients, 12% of placebo. Fever and arthralgias were observed in few vaccine recipients, none in the placebo group. Post-vaccine volunteers of all ages were seropositive to most serotypes, 83% seropositivity to dengue 1, 99% to dengue 2, 96% to dengue 3, and 87% to dengue 4, overall by day 180. Post-vaccine viremia was not consistently found. Antibody titers were higher as expected in patients with previous dengue. And very importantly, antibody titers to all serotypes remain stable in most adults after 3 years of follow-up. And in those without past dengue, it waned a bit quicker. So the authors concluded that within 3 years of follow-up, the single-dose tetravalent dengue vaccine was well tolerated, immunogenic for all 4 serotypes in young children to adults, including individuals with no previous dengue exposure. So I think the dengue vaccine space is expanding, and hopefully in this decade we will have a vaccine that is available to us in India. Okay, now the next 2 studies are also have impacted my practice a lot, because I do see a lot of patients post-sexual exposure who come in for advice. So there were 2 studies done. The first one, both published in the New England Journal of Medicine. The first one was this study involving MSM and transgender women, where they looked at 2 cohorts. One was a cohort where patients were on, people were on pre-exposure prophylaxis against HIV, and the other was those already diagnosed with HIV or PL-HIV cohort. And they had gonorrhea, chlamydia, or syphilis in the past 1 year. They were randomized 2:1 to receive either doxycycline within 72 hours after condom-less sex or standard care without doxycycline. STI testing was performed quarterly, and the primary endpoint was incidence of at least 1 STI per follow-up quarter. Okay, and I won't go into the specific nitty-gritties, but there was a significant reduction in the incidence of STIs in both cohorts, that is people living with HIV as well as those who are on pre-exposure prophylaxis. That you can see here, the relative risk of 0.34 and 0.38 in the people living with HIV cohort, 0.38. And the incidence of the 3 evaluated sexually transmitted infections were lower with doxycycline than with standard care. Okay, so and again, the relative risks for each of these infections, gonorrhea, chlamydia, and syphilis, were significantly lower in each subgroup. Okay, no serious adverse events were attributed to doxycycline. Interestingly, tetracycline resistant gonorrhea occurred in 5 of 13 in the doxycycline group and 2 of 6 in the standard care group. So that is something that we have to look at. So the take-home point was the combined incidence of gonorrhea, chlamydia, and syphilis was lower by 2/3 with doxycycline post-exposure prophylaxis than with standard care. And you can see here the forest plots clearly favoring doxycycline as compared to the standard care group across all STIs as well as in terms of location of the STIs. Sorry, this was the PrEP cohort and this is the PL-HIV cohort. And here is again the Kaplan-Meier equation which shows the same thing. Yeah, so again the interesting point about tetracycline resistance in gonorrhea, it was observed in about 27% of isolates, and that is depicted here. So moving on, this study was conducted after this and again was published in the NEJM. So this was looking at it was conducted in Kenya, 18 to 30 years of age, in women as well as, cisgender men, cisgender women. But here they looked at those who were receiving pre-exposure prophylaxis against HIV. Primary endpoint was any incident infection with gonorrhea, syphilis, or chlamydia. Hair samples were collected quarterly for objective assessment of doxycycline use. And 109 sexually transmitted infections occurred, 50 in the doxycycline post-exposure prophylaxis group, and 59 in the standard care group, with no significant difference in between group incidents. Among 50 randomly selected participants in the doxycycline post-exposure prophylaxis group, doxycycline was detected in 58 of 200 samples. So there was not great compliance, only 29%. And in this study, all the gonorrheal isolates were resistant to doxycycline. Okay. So among cisgender women, the incidence of sexually transmitted infections was not significantly lower with doxycycline than with standard care. But one of the confounders was that the uptake of doxycycline or compliance to doxycycline was pretty low at 29%. Okay. So this is what is depicted in these two graphs again. So if you look at first sexually transmitted infection and even the first chlamydia trachomatis infection, there was not much of difference. So, I mean, how these have influenced my practice is that in MSM and transgender women, in certain clinical scenarios, I may consider giving 200 milligrams of doxycycline as post-exposure prophylaxis, but not necessarily for cisgender women. So I think that some cities in the United States, like New York City, have started to employ this practice, but this is still not a guideline-based practice, or doxycycline hasn't been FDA approved for this. Now, a little controversial study, which was, again, this study involved HIV and TB patients. So, adjunctive tuberculosis for, adjunctive dexamethasone for tuberculous meningitis in HIV positive adults. So, the landmark trial by Dr. Guy Thwaites in 2004 in Vietnam showed that steroids did have mortality benefit in those with tuberculous meningitis. But there hasn't been a study done in those specifically with HIV. So this was that study that was done. Double-blind randomized placebo-controlled trial. HIV positive adults more than 18 years of age with tuberculous meningitis in Vietnam and Indonesia were recruited. They were randomly assigned to receive 6 to 8 weeks of dexamethasone or placebo in addition to 12 months of anti-tuberculous chemotherapy. Primary endpoint, very strong primary endpoint, death from any cause during 12 months after randomization. Okay. And I mean, if you had to be very nitty, if you had to be very scientific about it, you would say that there was no significant difference, because death occurred in 116 of 263 participants, that is 44% in the dexamethasone group, and 49% in the placebo group, with a hazard ratio of 0.85. The 95% confidence interval is 0.66 to 1.1, and the p-value is 0.22. So they had to conclude that it did not confer a benefit with respect to survival or any secondary endpoints. Okay. This is again seen in this graph. So here you can see group differences in survival in the intention to treat population. The 95% confidence interval is represented by the shaded portion. So there was a correspondence actually which the NEJM published, and I'm quoting that here, and I would tend to agree actually that definitive evidence to support the use of glucocorticoids in patients with HIV TBM has not been provided by this trial, yes, but there was a trend towards lower mortality, that is 0.86 hazard ratio in the subgroup of HIV positive persons. Okay, in the trial that Dr. Gaithwaite had conducted. So this could be a type 2 error where you need larger collaborative studies. And there was also some comments about using CSF cell count as a stratifying marker in patients with tuberculous meningitis, and then looking at that, for example. So the next paper, which was very enlightening, was burden of typhoid and paratyphoid fever in India. And this was a study which was conducted from 2017 through 2020. Weekly surveillance for AFIs was conducted. Incidence of typhoid fever as confirmed on blood culture in a prospective cohort of children between the ages of 6 months and 14 years at 3 urban sites and 1 rural site. And then they also had an additional urban site and 5 rural sites where they combined blood culture testing of hospitalized patients with those with those who had fever to estimate the incidence of enteric in the community. They looked at that data. Okay. So 24,062 children in 4 cohorts, 299 culture confirmed typhoid cases were recorded with an incidence per 100,000 child years of 576 to 1173 in the urban sites and 35 in rural Pune. The estimated incidence of typhoid fever from hospitals' surveillance programs ranged from 12 to 1622 cases per 100,000 child years, and from 108 to 970 per 100,000 child years among those who were 15 years of age or older. Okay. So what they concluded was that the incidence of typhoid fever in urban India remains high, with generally lower estimates of incidence in most rural areas. The 4 urban sites were Vellore, Kolkata, Delhi, and the 1 rural site was Pune. Actually, I'll skip a little bit for want of time, actually. So this was a study which is a new drug for trichuris, trichura, and hookworm infection. Emodepside is what it's called. Okay. So this was a phase 2A dose-ranging randomized controlled trial, and patients were 18 to 45 years of age with either trichuris or hookworm infection. They received various doses of emodepside, 5, 10, 15, 20, 25 or 30, albendazole at a single dose or placebo. And then the primary outcome was the percentage of participants who were cured, which was determined by the use of the Kato-Katz thick smear technique. Okay. And so this graph here shows you the projected cure rate and the actual cure rate between in both the trichuris, trichura, and the hookworm groups, and it was quite effective. It showed excellent activity against trichuris, trichura, and hookworm infection. So this it's a new drug, and I will mention here that the albendazole is really not a very good drug for trichuris. So in the cure rate was barely about 30% in this study. So emodepside is something that may be something to look at. One paper on malaria is what I'll highlight. This was increasing prevalence of artemisinin-resistant HRP2 negative malaria in Eritrea. This is just where Eritrea is. So they looked at increasing the percentage of patients with day 3 positivity, that is persistent falciparum malaria, 3 days after initiation of therapy, and there really was significant emergence of resistance to artemisinin, and they also looked at the Kelch13 mediated partial resistance. Okay. The last study that I'll highlight is A beautiful study done in China actually, where they used single dose rifampicin in household contacts of patients with leprosy. So they compared a single dose of rifampicin, a single dose of rifapentin, and placebo to household contacts of those with leprosy, and looked at 4-year cumulative incidence. And rifapentin was extremely efficacious in preventing leprosy. So if you see, there were number of cases of leprosy after 4 years. In the control group was 13, in the rifampin group was 9, and in the rifapentin group was 2. So that was a study. And because I missed one, I just had some close contenders. This was a study I thought I'll include, but I'm not seeing it very significant in our context. This is so single dose of azithromycin showed improvements in maternal sepsis, but not in neonatal sepsis or death. Then there are other studies on positive toxoplasma serology being associated with overall increased mortality. This was published in the American Journal of Tropical Medicine and Hygiene. Another paper on anti-malarial resistance in Uganda. One paper on rabies in the SARC region, but these kind of missed the bus. And there's a new vaccine also which has come out in the last 1 year, which has been trialed in Mali and Gambia. And last thing, there was another interesting paper that I found on heart rate variability as from measured devices as a marker of disease severity in tetanus. So, yeah.
Thank you, Venkat, for reviewing all the tropical, which I have not gone through all the articles. Two on dengue, one
Yes,
on
sir.
scrub, that interest trail.
Yes.
One in two on post-exposure prophylaxis.
Yes, sir.
One dose or multiple?
Yes, sir. No, sir. It's just of
Single
200
dose,
mg
okay.
doxycycline.
Then what is that drug for the hookworm?
Yes, sir.
So
Imodepside.
another is hemodepicin.
Yes, sir. Imodepside.
Okay, then you come rifapentin single dose for
Rifapentin for.
that is single dose for 6 months, or is it only one dose?
No, it's a single dose, sir. And they looked at cumulative incidence after 4 years
4
of
years.
administration to
Okay.
household contacts.
So then
Of-
you have commented about other which are important, tetanus, heart rate variability, and
Yes.
postpartal vaginal
Azithromycin,
azithromycin. I think for the paucity of time, any one question we can allow, because he has covered most of the infection disease for me at least. So any meningococcal vaccine also you.
Yes, sir. But
And do you see the dengue being eradicated with the effective vaccine coming in next decade at least?
hopefully, sir, it's a real menace in at least in the I don't know about here, but in the
This
in the
year
urban
we saw,
areas.
I saw a few dengue deaths,
Yeah.
because usually it used to be this year we had a more at least 2 dengue deaths I saw in our hospital with severe. So any one question we can allow. Anybody has got any question, because he has covered most of the tropical diseases which are very relevant. Thank you for wonderful presentation and
Thank you.
making us understand more about tropical disease.
We are about to conduct one more topic which is supposed to due in the morning, and we have a speaker, Dr. Haripriya Reddy Challa from AIG Hospital, Hyderabad, and she has finished her FNB in infectious disease and has multiple publications. And we have been seeing patients, a lot of patients coming with right upper abdominal pain nowadays, and most of them are fatty livers in diabetics or pre-diabetics, but with fever and other things. So we will be suspecting other causes, and one of them can be the liver abscess. Over to you, ma'am.
Thank you, sir. Thanks for the introduction. Thanks for the opportunity, and I bring warm wishes from my institute, AIG Hospital at Hyderabad. My topic is liver abscess in tropics, and I don't have any conflicts of interest to disclose pertaining to this current lecture. So any SOL in the liver, it need not be just infectious. There are other things like the terminology is little obscure. It is not malignant. It can be a malignant lesion or iatrogenic procedures causing abscesses or infections primarily infecting the liver. What are the different routes by which infection or the liver abscess is pathogenesis? So through blood, hepatic veins or hepatic artery or portal vein system, or through bile duct, bile ducts and gallbladder stones or malignant strictures through the biliary system, or in the continuous spread from surrounding intra-abdominal infections. These are the common, and it is very much prevalent in India, and in say Asia and Africa parts, its prevalence is higher. I will discuss few cases. Some of them are my own cases, some of them are my colleagues. So not all details for many cases, but I just want to show how varied the presentations can be and what could be the different etiologies of the same. So the first case is a 27-year male who's a dermatologist. He was admitted with complaints of fever, chills and right upper quadrant pain, malaise for 4 days. Bloods showed 12,000 of total counts, 89% neutrophils, hemoglobin of 13 and platelets 236. Mild elevation in alk phos and minimal elevation in trans enzymes. Ultrasound showed a 4x6 hypoechoic lesion in the right lobe of liver. It was suggestive of liver abscess. Patient was started elsewhere on cefporaxone sulbactam and was transferred to our center after 3 days. So he came on himself because he was not very happy with his own hospital. So, and then this is the CT done at our institute. It was showing both one picture A is a portal venous face and the second is a contrast enhanced image, both showing clustering and hypoattenuating lesions. So basically he underwent PC, single time aspirate, and it was about 20 to 25 ml of pus drained. It grew a pan-sensitive Klebsiella. He received ceftriaxone for 2 weeks. So basically this is a pyogenic liver abscess caused by a sensitive Klebsiella strain, straightforward case. The point is duration, how long you treat this pyogenic abscess which is drained. So there is no consensus, but if you're sure that the total abscess is drained, we can once the source control is coming, maybe we can stop at 1 week, but we were not sure because there are multiple small other pockets seen around. So we gave him like around 2 weeks of IV therapy with ceftriaxone, as it is pan-sensitive. Later we gave 2 weeks of ciprofloxacin also. This is how this case was managed. Coming to the next case, it's a 57-year-old male patient. Fever of unknown origin with right upper abdominal pain. He was roaming here there for 3 months and he was not having any prior comorbidities. He's given a history of chronic alcohol consumption. He underwent ultrasound which showed a well-defined lesion with heterogeneous solid appearing content, and then axial axial section CT showed double target sign, that is around the hypotenuse lesion there is a white rim, around it is the edema. This is called a double target sign. So this pigtail is kept, and this is what is seen. Anchovy sauce. So I was not knowing what was anchovy sauce. Only recently I got to know it. Anchovy is a fish and it's a sauce that is made from that fish, apparently. So this is differentiating amoebic and pyogenic abscesses. The usual, it could be right side, left side, one, many, but these are not very, mostly it is only a theoretic part. Serology, we usually, for amoebic liver abscess, we usually consider doing only IgG. We don't have antigen testing available as of I know. And the treatment part, antibiotics, and for pyogenic and for amoebic, it is metronidazole, and also you have to treat with a luminal agent. So coming to the next case, it is a 28-year female who with the right upper quadrant discomfort for 5 months. There was no fever. She's married for about 2 years now and she's anxious to conceive. So the surgeons evaluated her at first. Someone told there is some lesion outside in ultrasound, and she came to our hospital, and then case went to the surgeon's part. They have seen this. If you can see, I'm not sure if you are able to appreciate, within the 2 cystic lesions, there are white membranes that are detached. This is a typical water lily sign of echinococcus. So the surgeons, as per the protocol of the staging of this, they did a deroofing, laparoscopic deroofing surgery she underwent. And then they call us because they're not sure to give albendazole, yes, no, because she wanted to conceive. So then we were also, we saw we can't give albendazole in pregnancy, and we didn't have praziquantel. We somehow counsel convinced her to postpone her plans of conception because albendazole is like category C drug, which cannot be given during the first trimester definitely. So these are the implications we have. This is the WHO classification for echinococcus. Sorry, I think it is not visible. The treatment is based on the stage. If it is active, that is on the first 3 stages, the treatment is required. If not, if it is not viable, as in CE4 and CE5, it is just wait and watch. And also, unless if the size is big and there is like it is about to rupture or something. Coming to the next case, this is 30-year male from West Bengal with pain right upper quadrant. He presented to us he was having pain since November 2021 and with on and off fevers. These are his bloods, and with eosinophilia of 31% and IgE is high, CRP is elevated. The other workup was negative. Ultrasound showed a 6 into 4 centimeter of irregular heterogeneous SOL. He underwent a CET, which shows, I'll show the picture, which showed multiloculated rim enhancing hypodense lesions. PCD, percutaneous drainage was done, and the fluid didn't show any growth. So if you can see, the first picture is the first, second, third, A, B and C. These pictures are prior to the treatment. Basically, he underwent percutaneous drainage, and the fluid is subjected to the histopathology examination. So this is the liver abscess aspirate. If you can see, it showed numerous charcoal-laden granules, the yellow ones marked, and also with eosinophilia. So this is a patient with a right upper lobe, upper quadrant pain, liver abscess, eosinophilia, atypical liver abscess. This is basically, we are dealing with visceral larva migrants. That is because we were able to prove in this case, but some invasive parasite infection is what we can see. But this is unpublished case series considered for sent for publication. 7 such cases in which we are all able to prove diagnosis of toxocara in 2 cases. Others are mostly radiological and peripheral eosinophilia. So these he is treated with albendazole. This, if you see this post-treatment, the last 2 E and F, this is a follow-up imaging, and patient lesions can be seen resolved. This is yet another case of atypical liver abscess, which I seen during my fellowship. It's a 60-year-old lady from Asansol. She's a housewife, and she presented with 2 months history of fever and weight loss. She was having intermittent low-grade fevers, and no other system symptoms were not there. Abdominal discomfort was there without any loss of appetite, but 2 kg weight loss. CT abdomen done elsewhere, they have told her there is a mass and it could be a malignancy, so she presented to us for further evaluation. Investigations showed were not significant, except ESR was 98 and other LFTs and RFTs were normal. This is a CT imaging which was reported as grape-like clustered cystic lesions in segment 4, and also few linear branching areas tunneling between these lesions, predominantly in segment 4. This patient underwent ERCP and biliary sphincterotomy was done, and then they've removed a large flat worm. If you can see this is the actual worm that was removed from the patient. Those are the representative images I've kept for your understanding, because this shows the folded worm, actually, the picture. This is fasciola hepatica. We also had we were able to diagnose because we actually removed the worm in toto by ERCP. But I have another case which I've recently seen. This is also a 52-year male, 3 months history of fever, but he didn't have any abdominal complaints. He presented only with fever, and elsewhere abdomen he was told to have a liver abscess. They tried to aspirate the lesion, but there was no aspirate when they tried to do, and it was like dry tap. They treated, they kept him on ciprofloxacin and metronidazole. His fevers didn't subside. And at this point, he came to us. There was significant peripheral eosinophilia, and for this patient also, this is basically a typical liver abscess, which differentials being visceral larva migrans and fasciola, and sometimes a milioid also can present like a typical liver abscess. So cultures didn't grow, and we also tried to aspirate for this patient. Again, it was a dry tap. We couldn't get any fluid, and then I couldn't manage to get toxocara serology on this particular patient. I got some information that veterinary institute is doing fasciola serology. I contacted them, and this patient, they have done the kits. They are done usually approved only for veterinary purpose, but they told they can test. And this particular patient, they've tested with the antigen by ELISA method is what they have sent me a report, and it came actually positive. I really am not sure of validity and if it is actually, but this is what we have done. I thought I would just present it. So this, we treated it as fasciola because the first patient was treated with the nitazoxanide. For this patient, I have kept on nitazoxanide, but I managed to procure triclobenzole from WHO and also gave that to the patient. He is doing good. Lesions have came down in size, but and still some part of it remaining, and patient is asymptomatic completely. This is from my parent institute, Apollo Hospitals, Chennai. It's 16 cases of fasciola, out of which 8 they were able to prove by the worm they have isolated, and others through the typical radiological findings, which they have labeled as typical fasciola cluster of grape sign. They've actually, this is the work from the radiologist and ID department there, and they've told that it is likely if the patient has these 2 signs of tunnel sign and grape cluster sign, it is likely to be fasciola. That is what they've tried to, and all these cases were treated with nitazoxanide, and patients had good response. So when there is an atypical liver abscess, the common differentials will be VLM, fasciola and milioid. I couldn't get one of my patients, I couldn't get the imaging of the milioid. It was a typical honeycombing pattern, and blood cultures grew milioid. That was also a direct case. And there was another case which patient presented with PUO, abscesses in liver and in spleen. Patient was doing dairy farmer, that is, he's having 4 to 5 cows, and so with that history, and they have done only serology for brucella, which came IgG positive. We didn't do SAT as things were fitting. We treated it as brucellosis. He received amikacin and doxycycline. His symptoms settled for some time, and then again he comes back after 4 to 5 months. After the treatment is stopped, after 4 to 5 months later, there are liver and spleen. This time when we aspirated, it grew milioid. So it was we missed milioid because of it was treated as brucella previously. So that is a case I thought I'll share with you. I didn't have images of that. So this is from our center, AAG Hospital, gastrointestinal manifestations of milioid, a single center experience. It is published in 2017. There are 9 cases in which 3 of them had liver abscesses. In 2 there were also splenic abscess along with liver, and 1 there was a prostate abscess along with liver. So milioid also can be presenting as liver abscess, that is in Tropics. So then this is my last case. This is a 60-year male who has a past history of liver SOL in 2017. Biopsy showed granulomatous hepatitis, and he received ATT for 2 months in 2017, and he defaulted. With this past history, he had again developed symptoms of fever, abdominal distension since March 2023, and he was evaluated elsewhere with ascitic fluid tap and all. It was showing lymphocyte predominant, ADA of the 45 protein was high, and CB-NAT was done, but it was not detected. So, but with this presentation and with past history of defaulting ATT, they have again started him on HRZD elsewhere. and then he presented to from July, and then he presented to us in October with the worsening of symptoms after initial improvement with ATT. We evaluated him again. The ascitic fluid was showing more or less similar picture. Gene expert we have repeated, which came out negative. So his imaging showed irregular peripheral enhancing large lobulated lesions in caudate lobe of the liver, extending into adjacent both the lobes. And then they have also written with internal septations. It could be either neoplasm or it could be abscess. If he underwent again another liver biopsy at our center, which also showed granulomatous inflammation. Gene expert again came positive. Cultures didn't grow because patient is already on ATT from 3 months, July, August and September. So drug resistance TB was what we thought of, but we couldn't prove it, and we gave higher dose of rifampicin to this patient and added levofloxacin because we couldn't do much and we couldn't establish diagnosis on this patient. But later this patient didn't make it. He succumbed to his illness with neurological manifestations at his hometown is what I heard of him when I tried to follow him up. So this shows the, so we should have not jumped and started ATT right away second time when he defaulted. Maybe we should have tried to do the biopsy and cultures again the second time. Liver biopsy should have been repeated ideally at before starting the first line ATT in this patient. That would have been ideal. So this is my last case. So what are the different infectious causes of abscesses? To summarize, pyogenic abscesses, which can be polymicrobial with anaerobes also, and previously mostly they were E. coli. Recently there is a shift towards Klebsiella pneumonia in pyogenic abscess. Bacterial granulomatous disease can be seen with TB, also some NTMs, Brucella and Bartonella, acute viral and fungal diseases. Sometimes, very rarely, Candida and Histoplasma can also cause hepatic abscesses as a part of disseminated disease. And parasite infection, as we were talking, Echinococcus, Entamoeba, Fasciola, Ascaris. These are the other parasites that can cause liver abscesses. So to conclude, SOLs of liver needs thorough evaluation. Clues from history and CBP are crucial. Atypical liver abscess are sometimes tough to diagnose in resource-limited settings. Correlating with clinically and radiological function with multidisciplinary team will be helpful for the patient diagnosis and treatment. Thank you.
Thank you, ma'am, for showing us different types of organisms that affect. Any questions from the audience?
No, sir. Gene expert never came positive. And it never came positive. First time they did in ascitic fluid alone, CBNet, the second at presentation with it, but it didn't come positive. No, it is not.
I also heard that gene expert is positive.
Oh, sorry, maybe I mentioned it wrong. No. We didn't establish diagnosis of TB in this at all. It is only granulomatous hepatitis.
Madam, you showed the table. Viral hepatitis A, B, C causing liver abscess.
No, so this is not liver abscess, infections in general.
Okay,
this is
not
not,
the
no,
abscess.
just to discuss others, this was a good
Okay,
table,
okay,
so
okay.
I've just included it.
So I had one case which had a same like what you told. Patient had a liver lesion, initially thought as a HCC, then it was thought as tuberculosis. We did, but it was a milioidosis. I have treated and he is under follow-up for last 10 years.
Right.
Just you have completed before time, so I ask you a question for that. Yes. Yes, ma'am.
Isolated.
Only liver. Patient is still under follow-up. Most of the time it is both.
Yeah, my this one is out of a larger question. Before we arrive at the diagnosis, we may be facing a rheumatological disease when there is a lesion like this, like sarcoidosis or something like that, or it may be infectious. So, what is your broad guidelines to all of us, or mainly the postgraduates, or here?
For liver,
situation.
if it is a granulomatous hepatitis, there are multiple other, as I said, it is not established. If it is sarcoid is suspicion in the clinical setting is important. So if you have to see for other sites, are there any lymph nodes, are there chest involvement? So if it is for, and if it is only granulomas without any from the lesion and without any evidence of TB, and if patient is not symptomatic, maybe we can wait, or usually in such cases we end up treating ATT and steroids.
Yeah. Thank you.
Thank you.
Thank the speaker and also thank the organizers for giving us this opportunity. Thank you.
On behalf of both of us, I would like to thank Dr. Kavita, Nitin, and all the organizing committee for giving this opportunity to learn something more about infections, which we don't do study much. Thank you.
Thank you all the speakers and our esteemed chairperson for a wonderful and insightful session. Now we will be conducting the final round of infectious disease quiz. For that, I kindly request Dr. Praveen, Dr. Shivdas, Dr. Nitin to come on stage. Thank you.